To all, and I am delighted to have this opportunity and going to talk about orbital sinus foreign body management challenges and strategies. Very good afternoon to all, and I am delighted to have this opportunity and going to talk about orbital sinus foreign body management challenges and strategies. Wood has many pores on the surface which may serve as needles for the growth of the bacteria, can lead to infection and inflammation. Moreover, if not removed, wooden foreign body will be calcified, organized, and inflammatory granuloma can grow in the surrounding. In addition, they are fragile and difficult to remove in one piece compared with the metallic one. Wooden objects have been reported to penetrate the low resistance orbital corridors, and depending upon the velocity, they can either penetrate sinus, brain, or confine to the orbit and causing complications. Surgical complications are highest if located in intracorneal space or in relation to the important vital structures. So let's learn from an example. A young male present as a case of left eye orbital cellulitis with history of wooden injury and showed resolution with IV antibiotics. His CT scan revealed a hypoattenuating foreign body resembling air extending from the lateral orbit into middle ethmoidal sinus. It was touching the optic nerve and disrupting the medial rectus fibers. Attenuation of the wound changes from ISO to hyperdense with passage of time, as evident on CT imaging with surrounding inflammatory granuloma. Surprisingly, it was causing retinochoroidal indentation. The main challenge in removing any intraorbital foreign body is in obtaining adequate surgical access to retrieve with minimum surrounding tissue damage. A short video of the same patient, transnasal, transethmoidal approach was chosen to mobilize the wooden foreign body. Later, transconjunctival inferior orbitotomy was performed. Wooden foreign body was palpated adjacent to the inferior rectus. It is removed gently by grasping the tip and slowly pulling out with rotational movement. Attention should be paid to prevent any fragmentation. Interestingly, an acute angulation at the tip was noted. So what was unusual is a large size boot-shaped angulated bicompartmental foreign body removal. In the present case, lodged position could not allow open removal, and the considerable size could not permit endoscopic removal too. Hence, endoscope efficiently pushed back in orbit, making it removal easy. On follow-up, there was resolution in retinochoroidal indentation and significant improvement in vision from PL positive to 6/12. However, adduction limitation could not be reverted due to medial rectus involvement. Therefore, in nutshell, severity of the damage depend on the size, shape of step tool and trajectory force of the foreign body at entry point. The general principle guiding surgical treatment prefers direct visualization of the object and extent of injury, often referred as open in C. Timing for removal is extremely variable in the literature depending on the clinical presentation and severity of concurrent complications. Thank you for patience listening.
I think it was a very good video, but I'd like to ask, like, was the foreign body missed on the first go where the patient was on antibiotics for?
No, it was a diagnosed case, but actually, because of infection and inflammation, we defer the surgery. We plan to start the IV antibiotic, let the infection inflammation settles, and then
Then you all are gone.
then go for surgery.
So, but what if that foreign body? You said it was jutting into the optic nerve nearby.
Yes,
So,
yes.
isn't that
It was very close to the optic nerve.
Yes.
So two departments are involved, ENT department to mobilize it from the nose, and ophthalmic department we pull out without undue traction, without inducing the undue traction on the optic nerve.
Because
But of course, during the maneuver
he
can
was
happen.
lucky. No, he was lucky that he for 21 days the foreign body stayed adapted to the optic nerve, and yet the patient got 612 vision.
612 vision.
Yes, so I think yes, infection has to be controlled because sinuses are directly in contact with the the brain spaces.
Yes.
Anyway, nice video. Thank you,
Thank
Dr.
you.
Man.